everyone. This is CJ Gross. I am the founder and CEO of Ascension Worldwide. I'm also the author of the book, What's Your Zip Code Story? Understanding and Overcoming Class Bias in the Workplace. And I'm very excited about this conversation around healthcare equity with Dr. Leilanie Martin, who is a family nurse practitioner and also a professor in this very, very important field of healthcare. Welcome. So Leilanie, thank you so much for taking the time to talk about this extremely important conversation around health equity. But before we get into that, just let's tell the viewers a little bit more about your background in healthcare and healthcare education.
All right. And thank you, CJ. I'm so honored to be here today. I always enjoy our conversations, and hopefully our dialogue can bring about change and awareness. So my name is Dr. Leilanie Martin. I am a family nurse practitioner, and my background is in cardiothoracic ICU, also neurology. I spent some time there. And I am a full-time professor in the Family Nurse Practitioner program here in New York City. And I also teach for the University of Haiti.
Wow.
And I also am an entrepreneur with my own business.
Well, the first question I have is, how do you do it all, right? This maybe we should talk about health equity, but then also do a second podcast on, a work-life balance and managing, and you can have it all, or I don't know. But anyway, for right now, we'll stick to healthcare equity. So let me ask the first question. So how does health care equity impact people, and especially people of diverse backgrounds?
Well, CJ, I'm glad that you asked the question regarding what is healthcare equity. And first thing I like to do is define that, right? So health equity means that everyone has a fair and just opportunity to be as healthy as possible. Mm-hmm. Achieving this requires removing the obstacles such as poverty, discrimination, and the consequences of those, which is usually powerlessness. Mm-hmm. Also, we have lack of access to good jobs with fair pay, quality education, housing, healthcare, and safe environments all need to be part of that equation. And also something else that I want to say is that equity is not the same as equality.
Mm. So what does that look like in a healthcare setting? So I just went to go get my annual checkup, but let's say it's not that. Let's say during COVID, a lot of people were going into the urgent care to get checked on, hopefully if they felt like they had COVID. What might someone experience who's getting equality versus equity?
So also during COVID, that was the time where this really became highlighted of the health disparities. Mm-hmm. So first off, during the COVID pandemic, people who already were marginalized didn't have access to go get tests. They didn't have anywhere to go, right? And then those who don't have insurance, who could they call? So now you're at an urgent care, you're just a number, you don't have your primary care provider that you had a relationship with because maybe you don't have solid insurance because your job changes, because in this country, insurance is really based on your job. So if any of those factors happened, which again, when you're marginalized, there's more of a chance of that taking place. You're just out there now, and now you're not feeling well. You're in line with all these different other people. You don't have a private physician to call or anyone who even knows you. So to answer the second part of your question is, what does this health disparity do? It shortens life expectancies. You have quality of life issues, and it permanently alters family dynamics, making individuals widows and orphans prematurely.
Widows and orphans prematurely. So this, I think, falls right in line with the zip code story, right? So my understanding of the zip code is that this U.S. Census Bureau uses the zip code to determine individuals' life expectancy, their healthcare experience. So then when a person goes into to get healthcare provided for them, they're not getting equal or equitable experiences. And this is a trickle-down situation. It's not just, okay, I didn't get a good experience here, or I'm not getting provided for, but the healthcare component. I mean, obviously, if you don't have, proper health, it affects your work, it affects your relationships, it affects your ability to make money, it affects your quality of life. So when we think about diversity, equity, and inclusion, what are some of the things that, as you know, obviously equity impacts our healthcare, but in terms of, you know, people who have different backgrounds, and not just socioeconomic backgrounds, but color of your skin. I'm just get right to it, right? And I know it's been an issue in the past. I've had people who are not in healthcare, you know, come to me with different backgrounds, say, you know, is systemic racism, is that still an issue? And if so, I don't see it, right? And so this is really to educate people who may not have that experience, or maybe they have that experience, but they're so busy in life, they don't even know they're not being treated equally or equitably.
Absolutely. So systemic structural racism is still a thing, as we know, right? And so I guess the question would be like, how does that impact your experience in the healthcare system, right? So when you go to someone who looks like you, there's subtle nuances about things that you don't even need to explain. Even if you don't look like, if they have the same background as you, maybe they grew up, they understand where you're coming from, the beliefs, the cultures, the food, they may understand you better, right? Not may, they usually will, because there's just subtle things that they understand. Like, for instance, I'm from Chicago, a certain part of Chicago. If I meet somebody else from the South side of Chicago, we have a shared commonality. So there's things that I don't even need to talk about that we just know, right? So that's what happens in the healthcare field when you have interactions with people who are similar. But unfortunately, just because of structural racism and disparity, we have many individuals, persons of color, right, entering into the healthcare field who are being treated by people who don't not only understand them, but actually have inherent bias against them. So right there, that sets us up for lack of treatment. The algorithms are different. This patient's not going to follow up. Why should I waste my time? And even if it's conscious or unconscious, it's happening. And the statistics support it, that this is the thing.
And I'm assuming that it's happening in different, it's showing up differently in different environments, right? So if I'm close to, I don't live in Baltimore, but I'm close to Baltimore, right? So if I go to a city hospital or urgent care, just because of the nature of where I'm located, I may receive different treatment. And then also, you know, physically what I look like, and then maybe if I had a doctor in my title, someone might treat me a certain way versus maybe if I am more of a working class citizen, they find that out. And so I'm assuming it happens on the front end when you're triaged, and it happens when people are, you know, communicating with you to even share the things that, you know, I was in a hospital. I'm not in a hospital. I was going to get my my annual checkup, and there were certain things that I was like, I wonder why he didn't ask me this question. And I had no awareness that I may have been treated unequally. And I think this is the importance of having this conversation, to talk a little bit about the systematic part that is behind the scenes, right? It's happening in the development of processes and policies and all those things, and even the development of products and equipment. But then there's the social aspect, there's the communication aspect, there is asking that extra question that might determine something, or get some other information from the patient that helps you to make a better decision. So we'll talk a little bit more about that, but I also have a question about, so you are also a healthcare professor, right? So it's extremely important to make sure that we have more healthcare providers that are diverse, so they can communicate. As you said, someone else from Chicago, you're like, oh, you're from Chicago, and this person is complaining of certain things or whatever it is. So we might have that experience, right? So if a person is a provider who comes from like Asia, specifically Japan, there are certain things culturally they would know. Same thing in the African American community, same thing in the LGBTQ community. So how do we even get them in the door at the healthcare education part? Like, you know, I know that's a big conversation, but what are your experiences there?
Yeah, so no, that's definitely all part of it, right? So when we look at if you look at, let's just take, for instance, if you look at the medical faculty right now, 60% of them are white male, right? So again, when people tend to look like you, things happen on the back end as far as grading those things, about who belongs and who doesn't, who you can relate to. Then
Unconscious.
exactly, as we both know, right? And then you talk about other things, like even just the exams to get in have been shown to be inherently biased, right? So what we need to do in the education system, let's take it back as to where we're recruiting from, right? So we need to look at rural communities, because if you want, one thing about that is that there's about 15% of people who come from rural communities, but out of the medical providers, according to the American Academy of Medical Colleges, only 5% are from rural communities, right? Then when you take a look at the representation of African Americans, Pacific Islanders, it's just not there. So how do we fix it? So they need to get a pipeline, right? Maybe start going to where you find diverse communities. Like, let's look at the HSBCUs, right? Also reach out to our American Indigenous American or Pacific Islander communities, right? So another statistic that's interesting is that most of the individuals, or not most, but a majority of those who are in medical school are coming from the wealthy families, right? So we are still, these structures, even though we talk about diversity, inclusion, and equity, these structures in place are preventing this from happening. Also, the reason why is because of the cost of these schools, right? And all these programs. So we need to have more funding in those areas so we can kind of put the money where we're saying, because again, you may have a desire to go to medical school, but you're not getting accepted at the same rates because you don't have the preparation or the same advantages.
Wow.
Also in education, the way we talk about certain things and using the data to back it up, right? So when you go in there, meaning right now, things are starting to change with the terms of algorithms, right? So before it would be important when they're always like, put race, 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 race. This is a Black patient. This is a such and such patient. But now it's more like, how does this relate? Does this affect the care that we're giving them? Why are we putting this in the story? These are other things that are starting to, we see from the literature change, because those things also create biases that we didn't realize.
It sounds like that's a challenge too, because I would think in my mind, if I would assume that I'm not in the healthcare, so I'm going to step out on a limb here, that certain groups are susceptible to certain diseases or issues. So if you didn't put race down or maybe some other type of identifiers, all of that can be used as a bias, but it also could be used to better treat the person as well, right? How do you deal with that?
So what happens is, and this is what the whole miscommunication has been, a lot of these issues are because of social determinants of health. So you have patients walking around thinking that, oh, I'm Black, I'm automatically going to get diabetes. But when you look at the literature, it has to do with a lot of it, the social economic factors. One particular article was speaking about an indigenous community. When they moved where they were located and they started to eat processed food, the rates of diabetes skyrocketed. Now, were they diabetic because of biology? No, it was because of social determinants of health. So that's where these conversations become nuanced, and we need to explain to students as well as to our patients why we are here. And a lot of this could be you're eating potato chips because this is what you can afford. The whole foods that we want to eat or plant-based tend to be a little bit more expensive, right? So when you look at socioeconomic determinants of health, a lot of this has to do with why we're there.
So there seems to be a correlation to also like food deserts, right? I'm assuming, right?
Yes.
Yeah, I feel I'm stepping out there a little bit. So if you live in a food desert and you live in a lower economic, lower location where there's all these compounding things that could potentially put you at risk. Not to mention if you are a person of color, if you're male and a person of color, if your family, and again, I'm stepping out here. I've seen statistics that say, or research that says that your level of education also impacts your healthcare. And I know that's not, it's it's based on a lot of other factors, not just if you have a degree, you're not going to be, you're going to be healthy if you do, you're going to not be healthy if you don't. But the point is all of these factors come into play. And as that person, engages with their local healthcare provider, there is this, biases that are coming up. And then there's these systems that are in place that many of these policies and systems have been put in place before people were even born. And now they're just experiencing this. And so what is changing? That's my next question, to go a little bit to the policy side. Is it changing fast enough? And what is the pushback for change in healthcare when it comes to policies, when it comes to developing different practices? Is it because it's like, it's not happening to me or my population, or is it just because of pure, ignorance or, not really being aware of how it affects them? So I'm kind of playing devil's advocate here, because a lot of people might say, hey, if it was happening to your population, your identity, you would do something about it. And then there's other people that when we do the research on unconscious bias, the brain science is also impacting. So I said a lot there. What are your thoughts on all that?
Yeah, so policies, right? So when we talk about policies in healthcare, I always like to say policies are exactly that, right? So we create these policies, but to answer your question, there's so many policies in place about hiring practices, how we treat patients, so on and so forth, but the data doesn't reflect these policy changes, right? So let's just take, for instance, if we look at after COVID-19, or even before that, during that time with George Floyd, right? All of a sudden, companies were in an uproar. We have to change things. We need to diversify, so on and so forth, right? So at that point, they may go ahead and add on one person of color or maybe a woman to the board, or they may get a promotion. But then after that, nothing else changes. If you look at the company as a whole, or even the policies, right? So we have dozens of policies in place, but a policy is just that. But getting down and educating and changing people's minds and heart conditions, policies can't do that.
Wow. So then it sounds like, I'm going to try to use some medical terminology in the diversity world. Sounds like what you're talking about is a topical diversity solution, opposed to looking at the whole system of the problem. So because it's so hard to create the mind shifts, and I know for us, when we do diversity work, we are actually trying to get people to have an experience. It's really hard to have empathy for someone if you've never been in that position. It's really hard for you to, for my book, I interviewed one person who grew up pretty wealthy and well-to-do. And she said, I don't know what it's like to not be able to go to school. Now, I can say I don't want to go to school, but to not be able to go to school. And so if you put yourself in that position, if you're saying, like, I think you said 60% are white men who are in that position going to school to be providers. And then if you look at where those individuals are coming from, the circumstances need to be right. There needs to be the right environment from an economic perspective, and also the conversations that happen around the table, because you can have good grades, but if you don't have a system to support you to get to where you're trying to go, and then you have this divide where people are coming from different backgrounds and different experiences. And that leads to my next question. I mean, all of that's hard and all of that's challenging to deal with. And then there's another layer. I'm going to make it more complex, but you already know this. So in my book, it's about understanding and overcoming class bias in the workplace. And I know for myself, being and looking at the makeup of most healthcare institutions, you have an array of different socioeconomic, education functions, where people, in terms of languages that they speak. So when I think about class, I think about, yes, how much money did your parents make? What school did you go to? And all those things, but also where do you live? And, classification. When I went into one hospital, someone said, oh, those are the white coats. I don't know. I don't know if you've heard that as well. And it's people who are not non-providers, but are clinical, kind of having that conversation about people who are clinical and saying, okay, they're at this level, I'm at this level. So that's already causing a conflict. And then the scrub colors, right? So they said, okay, if you have this color scrub on, that means you work in this unit, this color. So there's also divides there. Then you have people from different countries that are coming into the space. And wow, that's a lot. I mean, how do you even try to wrap your head around that when it comes to class bias and all these different identities in healthcare?
Yeah, so as I talk to my students about it, so there's definitely a hierarchy in healthcare, no matter how you want to slice it.
Mm-hmm.
And all the things that you mentioned are constantly at play. So I do feel in that arena, just because of the professionalism, people have learned to exist, but there's a lot of undercurrents that are taking place because of that, right? So you can see like people definitely associate with people in their own hierarchical level. For instance, you will see that those who are providers, specifically MDs, they have their own room where they associate and do different things. You have your nurses. The nurse practitioners are in a weird category because they're providers, but depending on how administration has it outlined, depends on where they lie at in that, food chain. And then you have your medical assistants. But when you also look at it, you can tell that by the way people are treated. So some of the medical assistants, because of their pay rates, may end up having to not have the standard insurance that those of us who are providers have. So they may be on Medicaid. Right. So
working in the hospital.
Working in the hospital. Exactly. Working in healthcare because they may not either want to afford that insurance or because of what they're making, they can still apply for Medicaid. So you have all these things that play. And as you mentioned, the different cultural aspects, right? So then that's another thing that becomes a thing. So you have, if you're this certain ethnicity, you're assured to get hired in this unit because these are the ones that are dominating that particular unit. People don't really speak on it, but that's something else that happens. So you have different little cultural things that are happening is a nice way for me to put it in the hospital. So how do we make it right? Well, the one thing that they emphasize is that we're there for patient care. So that's the commonality that the leaders or administrators from everywhere that I worked, and some places do it better. That's our common goal. So that's what we have to come together on. But then, that's one thing we take care of patients, and it's another thing with your just social and interaction and your well-being and your headspace. So those are all things that I don't think they've really got a handle on how to deal with that.
Right. And I always say this, it's about who is asking you, do you want to go to lunch? Whether you want to go with them or not, or just that level of inclusion is something as simple as, hey, I'm ordering something, would you like something? Or invite you into a conversation. And so that's a whole nother challenge there. So let's shift now to talk a little bit about your experience in, being a professor and teaching students. How do you try to interject this concept around, diversity, equity, inclusion, and potentially even accessibility if it's a different approach into the education when you're now bringing everyone in and they're kind of filed down this hallway to get their education. And I know different levels, you have to go through more training. So I'm sure there's tons of biases that even come in the education part.
Absolutely. So that's a great question. CJ, me living in New York City is almost like a different experience because what we describe to our students sometimes is hard for them to relate. They can get it on. So for instance, we're in New York City where we're the most diverse, right? There's 800 languages here, even among the students in my classroom. So where there is diversity, we still have a lot of exclusion. So that's the part where I can, teach them, right? So we talk about many different concepts because it's on all levels with diversity. For them, the biggest thing is being nurse practitioners, right? So there's a certain kind of bias that they're going to experience with that because of just where we are in our society with that whole situation, right? So I think that's relatability that they all can relate to, right? On how maybe you'll be perceived by the providers or maybe by the other staff members because we have a role that it's been around for 50 years, but there's still a lot of different things, depending on the state that you live in, with practice guidelines, right? So we talk about that. We also talk about interactions in the staff. We talk about the hierarchy that takes place. And we also talk about treating patients, right? In terms of following the algorithms and really checking into our biases, because we all have them, and knowing that we have them and being very aware of them and making sure that when we're providing care for patients, we don't let that creep in. One example I would think about is I have students who work in the emergency room, and they may interact with undomiciled individuals, which there's a lot of just bias around that, right? So especially in the city and the things that are going on and the crime. So it's important when you're dealing with patients who maybe fall into that category to mitigate it and not just say, oh, this patient doesn't have anywhere to live, they're doing all these things, but to really treat them holistically as an individual. So just using examples like that to help my students so that they are aware that these things exist, even though we live in New York and everyone lives here, these injustices are taking place and we could be part of it. So we have to just be careful.
Wow. So there's obviously a lot of work to do on the front end, even before you get into the healthcare organization. So have you seen some organizations that are getting it right, or at least some front runners in terms of the work that they're doing and initiatives that they're doing around diversity, equity, and inclusion?
So, CJ, it's important because with all this work and these things and that what our companies are doing, you don't want to be the negative Nelly because at least they're trying, right? So when I think about healthcare organizations, I can't say any one sticks out in my mind. What I can tell you is that the organizations are trying. They have the diversity, equity, and inclusion committees. They are putting funding behind it, and they're doing all the things that they can at the top level, right? However, unfortunately, as we've had these conversations, when you start to peel back the layers and look at what's happening, you don't really see a lot of the change on the back end. And that has to do with, yes, you all are doing this, but you need to probably take a multi-tiered approach. Whereas you're putting these practices in here, but what about developing the talent that you already have? So as you already know, in a lot of these organizations, you may have it where you want to diversify, but what happens is because generationally or what has taken place prior than that, you already have people earmarked for these positions. You've given them the professional development, you've put them in the courses already. So when the time comes, they naturally ascend to these positions. So whereas you're speaking about diversity and inclusion, but you haven't taken these steps to develop any of the talent who would reflect that, right? So that goes back to my initial statement that equity is not the same as equality. So you need to use more of those resources and put more of an effort in to develop those individuals. So those statements are great, but I just think we need to have more concrete action and targeted action. Like by this date, we're going to do this. Kind of like what the NASDAQ has done, where now they've kind of issued a mandate, basically, that those companies on the New York Stock Exchange have to have a diverse board with 2 members. And if they don't comply, they have to explain why they have not.
Now, that's equity. That's a seat at the table. I think we still have to consider the socioeconomic and, kind of background, even if you have a diverse board, but if they're not diverse in that way, that's a whole nother issue. But just getting to putting seats and qualifying people who have diverse backgrounds sitting on the board, especially in a healthcare environment, I think is extremely impactful. So,
CJ, let me make a correction. It's not the New York Stock Exchange, it's actually NASDAQ who has done it.
NASDAQ. Okay,
yes.
Absolutely. Thank you for making that. So, and before we close, I have just one other question. So if I had a group of thousands, and now I'm realizing how many HR providers you have, HR professionals and recruiters you have in just one healthcare organization. My mind is blown, because I was just talking to my neighbor, and she said there's 70 healthcare recruiters for one organization. So 70, that's a lot. So if you had the ear of those HR recruiters, what would be some of the things that you would tell them to do in terms of, creating opportunities for diverse backgrounds of people to get into this process to become providers and get better pay, and to also make more impact in the care of patients?
I would say that there needs to be a dedicated program for it that has resources. So it's great to recruit the talent, as we spoke about, but we also want to have it that you're bringing in individuals who can succeed. And there's many different steps to that. So for instance, you can hire all these people who reflect it, but when they come into the organization, have the people who are in the organization been trained? Do you have a formal mentoring program? Do you have professional development behind them? Because what happens is, if you look at that, like, what is the attrition rate? You can bring in individuals, but if they're not structures for them to succeed and advance, it's all for naught. So that's what I would say for human resources. So if we're going to start these programs and we really want to diversify and our workforce, inclusion we talk about a lot, but we also need for them to succeed, right? And we want them to stay within the organization and have goals for them as to what our organization will look like 10 years from now. Not that, hey, we tried this back in 2023 and we hired a lot of people, but they're not here and we're not sure why. So speaking from personal experience, I've navigated a lot, but there's a lot of things just because where I'm at in my life that I knew how to mitigate. But even with that, there's so many things against you. Again, as a person of color, I say you always need to have the alphabet behind your name, but that still also doesn't help a lot of times, right? Because you need sponsorship, you need mentorship. And if you don't have those individuals to do that for you, and usually you will find people who don't look like you, who understand it and they're willing to take that chance. But again, if you have a formal program that just, we're doing this, it will make it a lot easier and companies can reach their goal instead of policies. But when you peel back the layers, the structures that are in place are still what is guiding the organization. And you can tell that from how things still look and operate. Same thing with healthcare and how we take care of individuals. We need to have those resources and these mandates to make sure that we're doing it and really invest in it and have outcomes as to what should be happening. These numbers should be going down when it comes to maternal death rates, for instance, right? So these are just some of the things that I would say, because we do a lot of talking. They have all these initiatives and I get it. And I hope that they are doing this because they want to see a change, but real change comes from the systemic changes and structures that are here that have kept us where we are for all this time.
Wow. What a way to end this awesome conversation about equity in healthcare. And what you just said was so amazing. I hate to say anything after it, but I will say this one little piece. It is definitely sounds like something that we don't quite talk about as much, or maybe don't understand, but it's definitely impactful in your industry, which is social capital, all the mentorship, the sponsorship, all those things are incredibly important, because if we could be very honest, in healthcare, it's very hierarchical, and then it's also very classist. It's like I hear people say all the time, oh, this person went to Harvard University. You can't even say it without slowing down a little bit. I've tried. You need to slow down. And I went to a program at Oxford, and when I started saying it, I was like, now I sound like those people. But that's a part of why it's so hard, because I wanted to say, yeah, I was a part of this program and I went to Oxford, but then the other people would say, well, why would you say that so much, right? And so it becomes challenging, because we don't want to take away what people have worked hard for. We want to acknowledge that, and we want everyone to have an equal chance to also work hard and accomplish their goals in healthcare. So this has been an amazing conversation. I'm so glad that we were able to have it, and I'm sure we'll continue to have different conversations around this. And so I've been talking to Dr. Leilanie Martin, family nurse practitioner and professor, and thank you so much for joining me on this podcast.
Thank you so much for having me, CJ. This was really great.